Good, thank you. Right, good morning, Ms. Barami, and good morning, Mr. McConnell, and those in the room. I'm very sorry for the delay, which was to do with a computer malfunction, but I hope it's all now sorted.
Good morning, Lord Brailsford.
Can you hear me?
Yes.
Good. Yeah. You've heard what I said then, did you?
Yes, we did. Thank you, my lord.
Right, over to you.
Thank you. Good morning, Mr. McConnell. Your full name's Eddie McConnell, is that correct?
That's correct.
Yep. And you're the Chief Executive of Down Syndrome Scotland.
That's correct.
Could you tell us a bit about the work that Down Syndrome Scotland does, please?
Yes, I'm happy to do that. So Down Syndrome Scotland is the only charity in Scotland that supports people with Down syndrome and their families from birth right through to their older age at every stage. It was established as a charity 40 years ago, just over 40 years ago, and we have 1,400 members across Scotland. 800 of them are what we call family members, parent carers, and 600 of them are adults with Down syndrome. We are supported by 10 local branches of Down Syndrome Scotland based in local communities, and they are organised by our parent volunteers. We have our work is very focused on supporting families and people with Down syndrome. We believe that every individual with Down syndrome has immense potential, and we also believe we have much to learn from them. So our job, our privilege, is to get right alongside families and right alongside people with Down syndrome to bring out that potential as best we can.
Thank you. Now, I want to jump forward a bit in your statement before going back a bit again. But at paragraph 27, you say that although you use the word resilient to describe the families you work with, they were only just about coping before the pandemic. To help us understand, please would you tell us a bit more about the general difficulties, pressures and responsibilities on those families who have a family member with Down syndrome?
Well, thank you. So what I can speak from personal experience as well as a father of a son with Down syndrome, and therefore I can really relate to what our families tell us. So many of our families face on a daily basis quite a lot of discrimination and barriers. And what they would say to us is that it's not because they have a child with Down syndrome, it's because of the attitude of others, which at one level might just simply be ignorance about the condition of Down syndrome. But at an extreme level, it's also about, and we have evidence of this, some discrimination and prejudice that takes place in terms of attitudes towards people with Down syndrome. So for families who have a young person with Down syndrome in their family, it's their daily experience is that they often have to fight to secure the rights of their loved ones, and it's a fairly exhausting daily experience. They have the same rights, our citizens with Down syndrome have the same rights as every other member of society, but on a daily and weekly basis those rights are often not upheld and sometimes quite blatantly violated. So for families it becomes a real fight to secure provision and support, whether that's in the early days in terms of medical support or interventions, or support to access education in the place of their choice, whether that's mainstream education or whether that's special need provision. All families tell us that is always a fight, and that continues throughout the life, whether it's then leaving school and accessing social care support. For families, they would wish that society understood the potential of their loved ones, and it wasn't so much of a fight to secure those rights. And the consequence of that is it becomes really exhausting for our families, because it is a daily struggle to secure those rights and those provisions that, of course, people with Down syndrome are entitled to.
Thank you. Now, moving back a bit, this section starts at paragraph 18 onwards. At the outset of the pandemic, you say that social care provision was withdrawn. Was this state-provided social care or social care that parents paid for, or both?
So it would be a combination of both, but in the main what we're reporting here is social care that was provided by social care providers that were often commissioned by local authorities to provide that care and support. So in a number of instances they are themselves charities, but they are also social care providers, and often, in most cases actually, commissioned by the local authority or the Health and Social Care Partnership to provide support to people, disabled people locally.
And what was the impact on individuals with Down syndrome and on their families and unpaid carers of this support being withdrawn?
So the families told us that the impact was huge because it was immediately withdrawn. There was no transition, there was no discussion about how we might move to a new set of arrangements. So it was, they received phone calls from their social care provider simply advising them that social care could no longer be provided. So initially it was a real shock for families. They were themselves, like many of us, trying to get their head round what was happening, and of course their main concern was about protecting their loved ones in that. And the provision of social care support is part of protecting and supporting them. So to have that withdrawn was for many of the families a lifeline that was actually withdrawn from them. It meant they became carers 24/7. It meant that they became carers overnight in many cases 24/7. And they were, although I described them previously as a resilient population, many of them were exhausted and very quickly were on their knees in terms of trying to navigate their way through the pandemic on their own because that social care support was removed. The impact on people with Down syndrome was really profound. It's really important for our community to have structure and to have support and to be part of wider society, and that's what social care facilitates. So to remove that so quickly means that people with Down syndrome lost their connections. They became very isolated. Loneliness was identified very quickly, and we know that their mental health deteriorated very quickly. And for some in our community, that manifests itself as behaviours that were different. Some people describe it as challenging. We would describe it as an expression of frustration. But that change in behaviour had then to be managed and supported by unpaid carers, family members on their own without that social care support. So it was really profound, the impact of withdrawing social care support and the uncertainty that went alongside that in terms of not knowing if this was a matter of weeks or a matter of months, and when would it come back, and indeed would it come back, was also quite a significant factor that many families talked to us about.
Thank you. And you actually mention being aware of a family that was asked to continue paying for the service despite not knowing when or if it would come back, so that they could keep their place. Do you know whether that family did in fact pay?
So it was a really difficult moment for everybody, and I assume therefore it was a really difficult moment for social care providers who were trying to understand what the future might look like, and we know that, we understand that, but it seems really perverse to us that social care provider would say to a family member, we're withdrawing your support, however we think it's best that you keep paying for that so that your space is there when things return to normal. Or return back. I'm pretty sure I'm pretty confident that the family member challenged that view, and I'm pretty confident the social care provider revisited their idea that the payment should continue.
Thank you. Now, you go on to say that support to families with caring responsibilities came a lot later on during the pandemic after much petitioning from organisations such as yours. Could you tell us about that petitioning activity? What forms did it take? Which people or entities did you have to petition? And what resources were required for that?
So throughout the pandemic and in those early months of the pandemic, throughout 2020, we were in constant contact with the Scottish Government's Learning Disability Policy team. Okay. They were, before the pandemic, our go-to civil servants in terms of feedback about what was happening to our community. So they were the natural place to engage with as we started to spot concerns happening. I think the challenge was that they were really receptive to our views and very supportive of our concerns. But their challenge was then to take that to the civil servants who were dealing with those concerns. So an example of that is that we were concerned that our family carers weren't getting the kind of level of support that we felt they needed. We were trying to provide that as a charity as best we can. Many charities stepped in to do that. And we really felt that as unpaid carers, they really needed some additional support, including financial support. And it became a very long journey through government, I presume, through different departments, probably up inside government and down, to eventually deliver some carer support through the network of carers charities that are based locally. But it came much later in the pandemic. We would also say, and I think I've mentioned this in my statement, that for a number of charities who have condition-specific charities, so our charity supports people with Down syndrome, we would have liked that support directly coming to us because we have that established knowledge and relationship with that particular group. And it seemed a very long way round to try and get support that was very generic and not specific enough for our community. So,
do you think a better approach might have been for those organisations that address a specific diagnosed condition, that they were to receive payments, and for those conditions where there is no specific diagnosis or there is no dedicated organisation, that for them it would go through a carer centre? So perhaps a dual approach would have been better and more efficient.
So I think one of the issues that we would reflect is that when we raised a concern with government through our established channels, we were not engaged in the conversations that took place to decide how to respond to that concern. And I think that's a pity. I think the consequence of that is that we could have influenced a different outcome, or, as you have put it, different options rather than just one option coming forward. So it was a frustration for us that we often lost the conversation once it entered government, because government had to speak with other departments. And then the solution that popped out was often not perfect. And then we had to work around and come up with additional solutions to make that more perfect. And I think there should have been greater flexibility, there should have been greater involvement of us in those conversations about those solutions. And there should have been greater choice about how that support was provided. I do want to acknowledge that we did receive additional emergency funding from the Scottish Government, but this point that we're focused on here is particularly about support for carers, which was primarily driven through the Carer Centres network.
What did the Carer Centres do with the money being given to them by the government?
So I think they attempted to reach most carers in their locality. I can certainly reflect that in my own experience as an unpaid carer. I was contacted by email, and I was sent some online resources, and I was invited to participate in some online sessions around wellbeing. but that support was very generic. And to be balanced about this, it was helpful for those who might have broader disability, but in the context of our community, people with Down syndrome, we have a very specific set of conditions, particularly health conditions associated with that. It was too blunt an approach. It needed to be more precise, and we felt that there should have been choice, and there should have been a direction of some of those resources directly into the relationship that we had with families and people with Down syndrome directly.
Thank you. Could you tell us, do individuals with Down syndrome have a named disability social worker that could help in identifying people and people that do have a need for funding and additional resources?
So many families who have a young person with Down syndrome, as they approach the end of school, will start that transition process, and often with the help of social work. And that will sometimes lead to the identification of a specific social worker who might support the development of a transition plan, and ultimately a budget to support that person in adulthood. The experience of that across Scotland is really extremely inconsistent.
Right.
So some people may have a named social worker. Some people may be in a basket. It's often referred to as a basket, and placed in a basket to see who's available in terms of a social worker to pick that case up. We know that many of our families are still not accessing the level of support that they're entitled to in terms of self-directed support and a budget. And as I said earlier, for many of our families, accessing that support is often a fight and a struggle. And it's often predetermined by the available resources rather than the needs and the support needs of the individual, which is what is actually set out in legislation in terms of the Self-Directed Support Act. It's meant to be driven by the needs, the identified and agreed needs, support needs of the individual. And often families report to us their feelings that it's driven by the available resources rather than the explicit needs, support needs of the individuals concerned.
And that was prior to the pandemic, so presumably the pandemic exacerbated that and made things much more difficult.
Yes, so I would say that one of the experiences our families have reported to us was many of the professionals who were involved in providing a range of different support, whether they were health professionals like allied health professionals or social workers, even in education. Many of those professionals stepped right back in the early days of the pandemic. So not only did social care get withdrawn almost overnight, for many of our families, that access to professional support stepped right back as well. And so they felt enormously alone and enormously vulnerable, more vulnerable, acutely vulnerable. And that's where organisations like ourselves and other organisations needed to step in and provide, as best we could, some of that support.
Thank you. And you've told us about the importance of socialising for those with Down syndrome, and you go on to say that whereas the general population were able to interact with peers and family online, that members of the Down syndrome community weren't accessible online. Why was that?
So our community is an enormously diverse community. So quite often, if you don't know our world, if somebody mentions people with Down syndrome, you'll think of some of the celebrity people with Down syndrome. Tommy Jessop, for example, who's a public figure, as we know, in the world of TV and media. Those well-known figures are really important in our community because they're really positive role models. But they probably only represent the top 5 to 10% of our community. So our community is a really diverse community. And as you move across that community, the communication support needs of that community become more profound, significantly profound. So it's really important that people understand that the diversity of the community in Scotland is quite extensive, and therefore the support needs of that community are really quite extensive. We always help people to understand that every person with Down syndrome is a unique individual, and they therefore have unique set of support needs, and it's important for people to really understand that quite clearly.
Yeah, thank you. And you say in your statement that the consequence of not being able to interact, at least online, has had an effect on confidence levels, and that the confidence levels aren't even back to pre-pandemic levels yet. Is your organisation's view that perhaps exceptions should be made in the case of people with Down syndrome and certain other conditions to allow physical interaction to continue in some way? And if so, do you have any views on how that could be achieved, outdoor interactions or any other way to ensure that this gap doesn't arise again?
So if you give me permission, I'd like to go back to the previous question, because I think I probably can provide a fuller response to the previous question, which will help answer this next question, if that's okay. So it's really important for people with Down syndrome to have structure in their lives, and to have those connections, and to feel part of not just their community, to feel part of a wider community. We believe that society benefits from having them closely involved. So the removal of that structure has a really profound impact on them. And as I said earlier, it does result in changing behaviours. It definitely resulted in examples of mental health and well-being deteriorating, depression occurring, and loneliness and isolation becoming very significant with that community. It's an interesting question about whether creating face-to-face opportunities or physical spaces for people to continue to meet may have helped. I think what was uppermost in all our minds at that time was keeping our community safe. So the notion of moving to create any face-to-face meetings was not considered something that we should be doing at that stage, because little was known about this virus at that point in time. We knew that people with Down syndrome, long before the pandemic came along, had significant health issues, have significant health inequalities. What the pandemic did was amplify them. So any idea of safely bringing people together was not in our consideration in the first year of the pandemic. So we relied very significantly on connecting our community through online platforms. We brought forward our digital plans, and within 6 weeks we rolled out a very significant online secure platform to allow our families to connect. Our motivations in those early days were about keeping our families and people with Down syndrome safe. But we also needed to keep them connected. That was really important, because that sense of connection is really vital in their lives, and we knew it had been withdrawn. So we introduced, for young teenagers with Down syndrome, we introduced our online Teen Space programme, which was regarded by many families as an absolute lifeline. The option for teenagers to come online and connect with other teenagers. And we did similarly for adults with Down syndrome. We created a Friends Space programme online. That felt the right thing to do, even though we were very conscious that for many in our community, they simply didn't have access to digital technology to take part. And the reason they don't have access is to do with that diversity of our community. So while some are very technically literate, others need considerable support, and others who might be, for example, in supported accommodation, often don't have the right to have access to their own technology and communication. And so while relying on that online world was the right thing to do, to try as best we could to keep people connected, we were very mindful that for significant parts of our community, that wasn't an option for them. So we placed for that community significant what we call kindness calls.
Okay.
We got in touch with families to understand how they were doing, just to have a conversation with them online. I think the whole access technology has been, on one level, really helpful, because we were able to connect people who were not connected before. So we were able to connect a family in Orkney with a family in Dumfries, when previously, without that online provision, we were unlikely to meet because of the distance. But they connected because we had an online provision. So that's positive, and we continue a lot of that today. The negative is that for quite a large, significant element of our community, they simply don't have access to digital technology in the way that you and I take for granted each and every day. And they need considerable support with that, which might be as simple as the provision of a device, but it will almost certainly be support to access and use that device in a safe and responsible way.
Thank you. And you mentioned there that essentially other health conditions, comorbidities with Down syndrome are well known, and there are some that could exacerbate COVID infections, but that those, but you mentioned in your statement that those with Down syndrome weren't initially on the shielding list. Presumably that would have caused some anxiety and uncertainty for those with Down syndrome and their families. And your organisation was involved in highlighting this issue. You then tell us that once that was accepted, I think following an Oxford study that showed those with Down syndrome to be at higher risk, that there was a gap between national government making that decision that people with Down syndrome should be on that list, and then the local health boards implementing that decision. Could you expand on the evident shortcomings in support and care following that decision?
This is a really important element of our submission, and it's really important that I emphasise that the health conditions of people with Down syndrome were well documented and well known about before the pandemic came along. We know that people with Down syndrome are prone to respiratory difficulties. We know that 1 in 5 children born with Down syndrome have a cardiac difficulty and cardiac challenges, and we know that their immune systems are compromised. So these are well documented, well known, for want of a better expression, risk factors associated with people with Down syndrome. So I guess we were really frustrated at the start of the pandemic that wasn't acknowledged and understood. And I think there's still a question to be asked why that. There's still an answer to be given why people with Down syndrome were not properly recognised as a high-risk group. I've said in my statement that it might be therefore inferred that people with Down syndrome were clearly left behind at the start of the pandemic, and it might be that some people with Down syndrome died as a consequence of not having been on, for example, the shielding list. So we petitioned quite strongly and continuously throughout that period. So the shielding list, if I recollect correctly, came into place in March 2020. People with Down syndrome were added to the shielding list 8 months later, in November 2020, and it came as a consequence of research that we supported internationally with what's called the T21 Research Society, which is a society that focuses particularly on research around people with Down syndrome. And as you rightly mentioned, the study conducted by Oxford University, which identified and confirmed that people with Down syndrome were in fact 10 times more likely to be hospitalised and possibly die if they caught coronavirus. The chief medical officers across the UK, on the back of that evidence, moved very quickly to issue a consistent letter across all the 4 home countries to say that people with Down syndrome would now be added to the shielding list. That started, I think, if I recollect correctly, that started probably in September, and it started to gain some momentum in October, and the letter was eventually issued at the start of November. And the issuing of the letter was then the start of another period of implementation. So our experience from families who spoke to us, who were really anxious why their loved ones were not on the shielding list, because they understood that being on the shielding list would provide additional support, would recognise that they had underlying health conditions and complex issues that needed to be acknowledged and supported. And they also believed, rightly or wrongly, that they might have prioritised access to a vaccine when it came along, and any additional health support that might be provided. It was a common experience of our organisation that once national guidance was issued, the filtering of that guidance to delivery and implementation at a local level took some time, and also was implemented not consistently. Not consistently sometimes within local health boards, and certainly not consistently across health boards in Scotland. We often found ourselves, and this is set out within the submission, we often found ourselves having to phone GP practices and tell them that people with Down syndrome were on the shielding list. And that came as a consequence of families contacting us and saying, I've been in touch with my GP, he's adamant people with Down syndrome aren't on the shielding list. We would contact and provide a copy of the Chief Medical Officer's letter. So there was a significant gap between national guidance and local implementation. And we stepped in to try and close that gap as best we could, but it was enormously frustrating for families. It created another level of stress. And it was quite clear that the communication channels were not well developed, and we found ourselves often being the one to tell health professionals of the changes that were happening nationally. So there's certainly, in terms of lessons learned, I think there's a significant gap between national direction and guidance and local implementation that has to be examined more closely in any future pandemic planning.
Thank you. And your view then is that that gap is largely down to inadequate communication at the local government level, is that right? Or local health board level, sorry.
Yeah, so I'm not sure we know why that gap happens. I think you probably have to ask others why that gap happens. All we know is that we found ourselves in a position 6 weeks after an announcement had been made, still telling people locally what the current position was, and having to, as I've referenced earlier, in the experience of families, having to fight for their rights, fight for their support. We find ourselves often, sometimes in quite combative conversations with general practitioners, with health board officials, to make them realise that in fact people with Down syndrome were now on this shielding list, and you needed to acknowledge that and now provide the additional support that came with that.
Yeah, thank you. Now, clearly during the pandemic, the work that your organisation had to do increased dramatically, and you've explained the reasons for that. And you do say that in time you received emergency COVID funding, but before that you had to dip into the organisation's reserves. The organisation had already been struggling to keep up with demand, so that placed quite a bit of pressure on you. While you were dealing with this, you then, of course, had to apply for the funding and wait for that to be granted. Could you tell us, amidst dealing with the day job, essentially, of the organisation, how did you find the application process and the steps required to be taken until funding was granted?
So maybe just a wee bit of context about how we how we as an organisation arrived into the pandemic, and you've referred to some of that there. So as an organisation, we were financially very challenged before the pandemic came along. I joined in August 2019, knowing that we had to look at restructuring the organisation to live within its means. We had a significant, it's a matter of public record, we had a significant legacy debt. So ironically, we had our own recovery plan in place before the pandemic arrived. When the pandemic arrived, we had to reduce the size of the organisation very quickly. Half of the staff immediately went on to furlough, and subsequently we had to make redundancies, significant number of redundancies of staff. About half of the staff group had to leave us at that point. So we were dealing with quite challenging issues ourselves as a charity, and as a consequence of that manifested itself as quite a challenging cash flow position. We know we weren't alone as a charity. We know many charities faced that problem. I would say that initially the emergency funds that became available flowed to us quite quickly. I would say that some funders really understood the importance of getting finance to us quickly so that we could continue the work we were doing. And I would say those processes were accelerated in a helpful way. It's really interesting that funders, including government, can really amplify their confidence in the organisation to do the work we're doing and how important that is. They can do that in the time of a pandemic, but when we recover from a pandemic, we find ourselves returning to a much more significant set of criteria and hoops that we need to jump through. So in some ways, we wonder why they had that confidence in us in a crisis. But now that the acute stage of that crisis is gone, we wonder why it's so difficult now to achieve the same level of funding and support. So though I would want to commend some of the funders for the flexibility they had and the speed at which they moved to release funds to us. But today that's a very different, we seem to have gone back to how things were before the pandemic. And yet it's really interesting that there was such a level of confidence in us as vital players to provide support to a vulnerable and marginalised community in the pandemic. They are still a vulnerable and marginalised community. That hasn't changed. So inquiries to our helpline peaked in the pandemic. They haven't come down. So they're still up at that level. We had a 28% increase in what we call complex support inquiries. 1 in 4 of our inquiries to our helpline are what we designate as complex inquiries, needing a minimum in that initial contact of 2 to 3 hours of support, but a lot of ongoing support. It's now 1 in 3 of our inquiries are complex inquiries, so the need is still going up. So, and yet the access to the resources that were available in that very flexible way is no longer available in that flexible, speedy way. We believe, like many charities, we stepped in and responded to the national emergency. We truly believe we saved lives. We genuinely believe we did that. But we don't believe that we are valued sufficiently now as part of the national response and part of the recovery going forward. And we're really disappointed that the contribution we made then has not been supported to continue as the country tries to move forward and recover. And we still believe that we're in that recovery stage.
You, of course, raise a very interesting point, Mr. McConnell. I don't doubt anything you tell me. It makes common sense to me, to be perfectly frank. The problem, or the issue I have, is that the situation you are in now is out with my terms of remit, or the terms of this inquiry's remit. We have, as you know, I think, specific dates which terminate in the end of 2022. I understand that I would probably be entitled to make comments about recognition that you deserve for the work that you did, your organisation did, but it's difficult for me to say anything about the position you find yourself in at the moment, I'm afraid.
Thank you for that, Lord Brailsford. I understand that completely. Perhaps the point I was probably making was that in the pandemic, people really valued and understood the contribution we could make. And it's disappointing that that is not, lots of innovation, different ways of working prevailed. People came together in a different way of working. And perhaps the most obvious example wasn't from our own community, was actually the speed at which people who were homeless were moved off the street within a matter of weeks. And who would have thought that was possible before a pandemic came along? So some of the innovation that came as a result, and some of the developments that came as a result of responding to the crisis, by putting people together and working closely together and being, in a sense, less concerned about whether you're third sector, public sector, health sector, but that you're focused on people who need the support. It's I think, as a lesson learned from the inquiry, we would hope that that lesson would be amplified, as something very good that came out. People work differently together, and understand going forward it's beyond the remit of the inquiry to necessarily say what's happening today, my lord.
Certainly the general point you make is something that can be considered and made if need be.
Thank you.
Thank you. Now, you mentioned your staff taking calls from the public and the number of complex calls, which you class as calls requiring more than 2 hours, increased. You've also said in your statement that the nature of those calls changed. Before the pandemic, the calls were really mainly focused on Down syndrome itself, but during the pandemic, people called you in relation to their mental health, their concerns, lack of benefits, or benefits, I suppose, not covering all of their needs. And then you go on to talk about a parent who became so desperate for help for her daughter that she actually harmed her daughter, as she thought that was the only way to obtain help. Could you expand on that? In particular, why did she think that was the only way to achieve that aim? And was she then, in fact, able to achieve that help, or to get that help?
So I think it's important to recognise that for many of our families, they became very desperate. They became because the support they had experienced had been withdrawn. They were really, really anxious and really worried. The nature of the calls, which quite quickly, pre-pandemic, are about Down syndrome and adjusting to having something to do with Down syndrome and what that means in your life, were replaced by conversations about stress, about worry, anxiety, mental health concerns, about impacts with benefits, about not having sufficient funds, and all of that happening when they were 24/7 carers.
Yeah.
So looking, understandably wanting to really look after their loved ones to the best of their ability, but doing so 24/7. So they were exhausted, and many of them continue to be exhausted today. And I don't, and we would never pass judgment on somebody who was so desperate that she was getting no support from, in that person's case, from social work, and felt that the only way to get that support was to do something quite disastrous, to, in a sense, invoke statutory involvement in her family, because her view was nobody was responding to her pleas for help. And so she took that really desperate measure, really desperate, and we absolutely do not have any judgment on that in terms of, it was clear she herself had very significant mental health needs that were not being supported or recognised. It's uncertain, and I would say for the record, it's, because there was statutory involvement in terms of the police, it's uncertain whether she actually did harm her daughter. So it's important for us to just acknowledge that, she alleged that she was going to harm her daughter, and she saw that as the only way to get support because nobody was listening. She was absolutely at the end of her tether.
Do you have any thoughts on how that could be avoided in future? Is it simply an issue of resource, or are there other steps that could be considered?
I'm reluctant to always come back to resource. I'm sure that's a tired argument that lots of people hear. I think one of the more significant issues, and again I mentioned this within the submission, is the gaps in data that exist for our community. So many people with Down syndrome are not known to local authorities. They're not identified locally. They're not on any register. That became abundantly clear to us in the pandemic when we found ourselves having to pass on information to GP practices, to local health boards of people we knew about who had Down syndrome that were not appearing on their lists and were therefore not receiving a shielding letter or were not receiving an invitation to vaccine. So there is this notion that's often referred to across our community and other charities of the invisibility of people with Down syndrome. So I think one of the issues is that data collection needs to be significantly improved. There are significant gaps in knowing where people with Down syndrome who are a vulnerable community, who are significantly marginalised, knowing where they are. And that we would argue that has to be prioritised going forward, and certainly as part of any new planning for any new emergency, that has to become a priority. So we were very much doing that retrospectively in the pandemic because we knew from families contacting us that they hadn't received a shielding letter or they hadn't been in any contact with the vaccination as it started to roll out. So I think this issue of gaps in data is very significant for people with Down syndrome and more broadly for people with learning disabilities in Scotland. We often say that we know there are 4,500 to 5,000 people with Down syndrome in Scotland, but we quickly support that with a qualification that is almost certainly a very significant underestimate because of the gaps in data. So while resources are really important and directing those resources, I think of equal importance is addressing the invisibility of many people with Down syndrome by improving data collection and ensuring those gaps are closed.
Thank you. Now, I'd like to move on to the impact of school and day service closures, and I think it relates back to this issue as well of parents having to take everything on themselves. A lot of parents were having to homeschool their children who didn't have health or genetic conditions. Where parents were trying to homeschool their children who have Down syndrome, particularly if they also had other children, presumably that would be more demanding. And you mentioned there was an abundance of general materials for homeschooling children, but that those with children with Down syndrome found those materials overwhelming. Am I correct in understanding that those materials were of limited benefit to those with children with Down syndrome? And if that's correct, is it your view that education authorities should have developed more specific materials?
We're definitely of a view, and families have told us this, that the homeschooling support was not at all adequate. It was not, and there will be exceptions to that. There will be, we should acknowledge that. But across the board, what we were hearing was that the needs, the specific needs of our community and the wider learning disability community weren't really properly recognised in terms of resources that were being made available. So there seemed to be this rush to just get as much resources to families as possible, without at the same time thinking, how do we need to adapt this resource for people who have additional support needs? So in many instances, parents found themselves having to invent that themselves. It was a consistent feature at that time when young people were being homeschooled. It was a consistent feature that families were reporting just feeling completely overwhelmed. They had the 24/7 responsibility as an unpaid carer, and now they were being asked to take on responsibility to homeschool with resources that didn't really facilitate that in any effective way. So many of our families simply pushed that information to one side because it overwhelmed them. And that's a common feature of some public institutions who I think are motivated to say we must get the as much information as possible to all of our families and to all of our communities. But we would encourage them to step back and understand how that information is delivered, how it is made inclusive, and how it is made relevant to the particular communities. And there was no nationally consistent effort around all of that. So we have been clear on the submission that we think going forward there needs to be some sort of national standards agreed about what that looks like. Our view is that people with additional support needs were not heavily considered, not in a prioritised way within the efforts made by education authorities. And certainly that's what families told us, and they felt very, with exceptions, there are exceptions to that, and we know that, but they felt very abandoned, is the word they often used when talking to us.
Thank you. And for the parents themselves, you say that employment gives them a moment where, and you're hesitant to use the word, but you say where they can be normal, and that was lost. So they were, as you've said, 24/7 carers. But you also say that some of them found themselves out of a job as a result of their caring responsibilities. Did those parents decide to leave their jobs, or were they terminated by their employers because of their other responsibilities?
I think probably in most instances, parents were trying to juggle too much, and in the instances where some found themselves out of work, they probably took that decision because they weren't experiencing a flexible employer who was going to support their situation, and they realised that they could not continue to work full time while also being a 24/7 carer. So I think it would be fair to say that those families who did that, who found themselves out of work, probably initiated that as a survival mechanism. You know, that's how they thought we were going to be able to survive. While there will have been some employers that were really supportive, and it was certainly the experience that a number of families found themselves having to give up work, or certainly reduce significantly their hours of work in order to deal with and the pressures that they were under.
Thank you. Now, there came a point, of course, where the restrictions started to ease, and when children started to return to school or day services. You described that return as being horrific. Could you please tell us why you describe it in that way, and what way was it horrific for the children and for their families?
Many of the families advised us that they were really, really worried about the return to school because there was no clarity about how infection control would occur in school. And they were really worried. So many of the families simply didn't let their children return to school. So they were then even more on their own, trying to do their best. But at this point, of course, they had realised that their young people were 10 times more likely to die if they caught the virus. So their anxiety level was significantly heightened. So understanding that, alongside a call to just get back to school, when there was no clarity about how infection control would be managed, and there was I think it was quite common for people to hear that there was breakouts of COVID happening in the schools, either in the teaching staff or indeed with pupils. So the consequence of that is that many of our families simply didn't return their children to school because they were just so terribly worried that in the absence of clarity about how infection control would be managed, they would find they would expose their child or young person to even greater risk. So the consequence is that the unfortunate consequence is that they became even more isolated. They became even more worried and anxious and even more stressed. And that combination of things was described by a number of families as quite horrific.
Thank you.
Can I ask a question at this stage, please, which really harks back to something you said a little while ago, Mr. McConnell, and it's simply a point of clarification. I fully understand what you've just been saying about the concern that parents of a Down syndrome child had because of the vulnerability of their offspring when they were going back to school. But a little while ago you said that Down syndrome sufferers those that had Down syndrome were 10 times more likely to contract COVID and the consequences therefore. Did you mean when you said that the entirety of those that have Down syndrome, or were you specifically referring to 10 times more likely for children? The reason I ask is because I think we know as a matter of generality that children were much less likely than adults to contract COVID in the first place.
Thank you, my lord. I think it's an important point of clarification. So the Oxford study that identified that people with Down syndrome were 10 times more likely to be hospitalised or indeed die should they contract COVID was focused on adults.
Focused on adults.
Yeah, and that's the factual situation.
That's the factual.
Yeah, but nonetheless, in the absence of any similar study for children and young people, you can imagine the parents, as a consequence, knew
absolutely.
that and were extremely anxious.
And indeed, to be fair, whilst it may be the case, I think medical evidence is the case, that children were less vulnerable, I think in the absence of specific evidence to the contrary, one would be entitled to assume that even if children were less likely to contract COVID, a child with Down syndrome was 10 times more likely, even from a lower base, than other children. As a working hypothesis in the absence of information.
Yeah, and I think that's reasonable for families to adopt that as their approach in the absence of that clear information being available to them.
Don't disagree with that at all.
Thank you.
Thank you. Now I'm just keeping an eye on time as well. So I'm
going to obviously allow you a little longer than, well, I'm going to allow you your full quota of time. We started late, so you can finish late.
Thank you, my lord.
But you are actually running towards the end of
yes.
On that basis.
Yes, thank you, my lord. Mr. McConnell, can you tell us about the impact of the pandemic on pre- and postnatal care of those who were told while pregnant that their baby had Down syndrome? Was that at around the same level, or was the support through the NHS reduced?
So when a family or a mother receives a diagnosis antenatally or postnatally that their child may have Down syndrome, or a confirmed diagnosis that their newborn child has Down syndrome, a number of things swing into place quite quickly. So our charity will quite quickly be involved with that family, and we quite often have referrals. So the physical connection with that family wasn't able to happen because of the restrictions for a number of those families where a baby was born with Down syndrome in that period. Like many families themselves, they were also very isolated themselves in that health setting, so it was particularly difficult for them at a time when support is really needed to help them make the adjustment and understand their maybe unexpected news for some of them, because for some of them it is unexpected news. So I think it was particularly difficult for those newborns in the pandemic. We certainly made sure that resources were reaching them. But one of the things that's really powerful for new families is putting parents in contact with other parents. And while we were able to do that online, it's really powerful for a parent to meet another parent who's been through the same experience, and then we weren't able to do that. So that's a significant element that was missing from their reasonable care at that point in their lives.
Thank you. And I want to move on to speak about the clinical frailty scale. Now, my understanding is that scale is designed to apply to people who are perhaps elderly or through or who have a condition that is terminal and they are close to the end of their life. But during the pandemic, you found that it was being applied to those with Down syndrome, and your organisation took action for that. When you contacted the government, how did you find the response, and how quickly did they react?
So I would have to say that they responded in shock initially when we contacted them, to make them aware that a number of families had reported to us that their loved one was possibly not going to be prioritised for treatment. They were in hospital, but they were not going to be prioritised because somebody had inappropriately, completely inappropriately used the clinical frailty scale, just because the person had Down syndrome. And that's a wholly inappropriate use. And indeed, I have to say they moved very quickly, and guidance came out to say that the clinical frailty scale should not be used in determining support and treatment for people with learning disabilities, and in particular people with Down syndrome. So that, I have to say, that happened very quickly. That guidance came out. Of course, it was just guidance, and we're always aware that when it's guidance, it doesn't carry a statutory. It wasn't a statutory instrument, and the consequence of that is we then redouble our efforts to make sure people know locally that this guidance has come out. But similar to my earlier comments, the gap between that national guidance coming out and local implementation was very varied. And of course, there's that substantive point that it remains guidance as opposed to an instruction or a statutory instrument, if you like.
Yes. And you make the point in your statement that generally across primary care, and I think implied in that also is in hospital care, that some seem to view the lives of those with Down syndrome as less worthy than others. And you give an example of a man in his 20s who attended the cardiologist with his mother, and the cardiologist during the pandemic said, "I do not know whether it's worth operating on someone like him." It's quite a profound statement, even if they're not mistakenly using the clinical frailty scale. What happened in that case? Did the young man get the treatment that he required?
So my understanding is he did get the treatment he required, but it required an intervention from us as a charity to explain why that was a wholly inappropriate response. This is an issue that our community sadly live with day in, day out. There are many great health practitioners, many great medical professionals who understand the value of people with Down syndrome, and who understand that Down syndrome is a genetic condition. It is not a disease, it is not an illness, it is a genetic condition. And that what you need to focus on is the health conditions that might be associated with that. But never, ever use Down syndrome as a reason not to treat people or not to prioritise them for treatment. We know that despite the efforts of the last 40 years, where we have extended life expectancy of people with Down syndrome, when the charity started, life expectancy was just 20 years. Today, life expectancy is 60 plus, 70 plus. But it remains the case that for people with Down syndrome, they continue to die on average 28 years younger than the general population. And in the majority of those cases, those deaths are preventable and certainly premature. And we know from research conducted by the University of Glasgow that it is often ignorance and prejudice about the condition that results in people having wholly inappropriate views about the individual who just happens to have Down syndrome. So the person was supported, but it required a very heavy intervention by our charity to bring about a different change in circumstances.
And so these views exist generally, but during times of stress on the NHS or during pandemics, it just becomes much more prevalent. And presumably if somebody isn't used to working with your organisation, then they have to either deal with this themselves or just accept the view of the clinician that their child isn't someone worth carrying out this treatment on.
So we're very clear that at best it's ignorance that creates that view of a clinician, but actually in some cases it's definitely prejudice and discrimination. So we work very hard as a charity to tackle that through training. This is an issue that has existed for our community long before pandemic came along, but it amplified. It was amplified. And we were shocked to discover how quickly it came to the surface and how prevalent it was in the pandemic. So we've always known it's there, but we were quite shocked. And the most obvious example of that was in the conversations around do not resuscitate orders.
Yes, and I actually wanted to come on to that now. So do not attempt...
about 10 minutes.
Thank you, my lord. The do not attempt cardiopulmonary resuscitation or DNA CPR. You mentioned in your statement that a seriously ill woman in her 80s received a call from the GP in respect of her fit and healthy son who was in his 40s, with the GP stating that she wanted to place a DNA CPR decision on the woman's son's file. And the woman, you say, was quite surprised by this. She perhaps, you imply that she perhaps expected a call in respect of herself, not her son. Do you think that that was an isolated incident? Or do you think that these conversations in respect of people with Down syndrome were taking place very frequently?
So we definitely know it wasn't an isolated incident. We know that a number of families had unsolicited calls from, in this instance, that particular example, from the GP's practice. Mum in that instance was actually very confused as to why the conversation was happening, because her own health was extremely compromised. Sadly, she's no longer with us. She has passed away. So she was confused why the call was about her son, who was in his 40s, a very fit, very active, healthy man, who in fact had no significant health conditions. So she moved from a position of confusion, reached out to us, to a position of real anger, because she could only her only rationale for that conversation taking place is because the GP that made contact had decided that because her son had Down syndrome, that maybe we should just put, if you forgive me for using the short term, do not resuscitate order in place, just in case. And it's completely wrong. It's completely unacceptable, and it reveals terrible bias, and frankly we would say prejudice against somebody who happens to have Down syndrome. We moved very quickly to escalate that within Scottish Government and within Public Health Scotland. I have to be honest and say that the response we had to the clinical frailty scale issue was quite rapid. I'm probably less clear what the response was on the do not resuscitate orders, but I know that guidance was eventually issued after a number of months to be clear that while people with Down syndrome are part of society in general, and we know that society in general, there will be times for conversations about the appropriateness of a do not resuscitate order. It can never be justified to have that conversation just because the person has Down syndrome. Down syndrome is not an illness, it's not a disease, it's a genetic condition.
Yes. And to your knowledge, did the GPs listen when people said they didn't want this, because we know that clinicians are able to place such notices on people's files regardless of agreement, best practices that they discuss it. But in these cases, did GPs proceed to just place these notices on people's files, or following a conversation with the families, did they agree that it wasn't appropriate?
I think our recollection is that following another heavy intervention, most stepped back.
Okay.
We couldn't be certain, though, that these orders weren't, and we certainly know of one family where an order was put in place wholly inappropriately without the knowledge of the family. So that was completely unacceptable.
Yes. And you say that eventually perhaps some communications were put out that this was inappropriate. Where a notice was placed on a file, do you know whether that led to GPs revisiting previous decisions that were based solely on an individual having Down syndrome, or do those individuals still have DNA CPR decisions on their file?
We don't know for certain, and one of our challenges is that the families who reach us, we often believe there are other families who don't reach out to us, who maybe, because of other pressures they have in their lives, be very deferential to that clinician's viewpoint. So we do know that even if it's one family that reaches us, we have to respond, because we suspect there are many families who haven't reached out to us and find themselves in a similar position. So I can't say with certainty whether those orders still sit on their files or not. I think it's probably for others to answer that question.
So thank you very much for your time, and we have in your statement as well lessons that you believe should be learned, and we've covered some of those in the course of your evidence. Is there anything, and we will take all of that, of course, into account, even the points that we haven't covered, is there anything in particular that you're keen to emphasise that we haven't discussed already?
Well, thank you for that, and thank you for the opportunity today. And I do want to go on record and say that this has been a really supportive experience, and meeting with all the staff at every stage. Lord Brailsford, in this process, the staff in the inquiry have been enormously supportive and helpful in allowing us to bring these issues out and give voice to people who very rarely are heard from in terms of people with Down syndrome. I think the most important thing that we must learn and recognise is that there remains a view, and while we've made progress, there remains a view that people with Down syndrome are not as equal as other members of society, and we really need to be vigilant in the planning, in the new planning for any future pandemic or any future national emergency. I think our sector should be much more closely involved in the planning, much more respected as an equal partner in that planning process. For many of us, it felt things were being done to us, and we were reacting all the time. And so I think going forward, a really important lesson is to recognise and value the role of charities like ours in planning for a future emergency, and to really value and appreciate us in every stage of coping with a future emergency going forward. Fundamentally, we believe people with Down syndrome are people of immense potential. We believe they have an awful lot to teach us, and we have a lot still to learn from them. So we must do everything in our power to protect and safeguard them in any future national emergency.
Thank you very much for taking the time to join us today.
Thank you.
Thank you.
Yes, indeed. Thank you, Mr. McConnell, for your time. I'm sorry you were delayed this morning on the start.
Thank you.
Very good. We'll give it about 15 minutes, which means probably just before 11:45. Thank you very much indeed.
Thank you.
Now, good morning, Mr. Stephen. Can you hear me all right?
Good morning, my lord. Yes, I can.
Very good, and good morning, Miss Fraser. I'm very sorry for the delay in hearing your evidence this morning. We experienced, I don't know if it was computer or internet difficulties, but one or t'other. We've held you back. I'm sorry for that.
No problems.
Good, thank you. Mr. Stephen, when you're ready.
Thank you, obliged, my lord. Good morning. Can I ask you to confirm your full name, please?
Yes, my name is Stephanie Mary Fraser.
And your full title is Baroness Fraser of Craigmaddy, but I think you're content to be called Stephanie for the purposes of today.
Completely happy with that,
I'm obliged, thank you.
Apologies, Lady Fraser, I wasn't aware.
It's all right, my lord.
Your age and contact details are known to the inquiry, so I won't ask you about those, and you've already helpfully provided a written statement. And for the record, the inquiry reference number for that statement is SCI-WT0461-5 zeros and a 1. Are you content for that written statement and the oral evidence you're going to give today to constitute your evidence to the inquiry?
I am.
And are you happy for that evidence to be recorded and published?
I am.
Thank you. And everything you said in that statement and indeed today will be taken into account by the inquiry, even if there's something that we don't touch on. And final reminder, just on housekeeping, I suppose, is there is a restriction order in place, so please don't mention any individual names when I'm asking you questions. If it's a staff member, please refer to them as such rather than their name. All right, thank you. Now, the organisation you're representing today is Cerebral Palsy Scotland, is that correct?
That's correct, yes.
And formerly that organisation was known as Bobath Scotland?
Yes.
Which leads me to ask you two questions. What is Bobath and why the change of name?
Bobath is a therapy concept that is internationally recognised as a management for cerebral palsy. It was the first therapy concept that, cerebral palsy is caused by damage to the infant brain. The damage to the brain doesn't change throughout life, but how cerebral palsy affects you and how that damage affects you can become progressively worse as you age. The Bobath concept was the first to look at actually functionally and clinically functionally how someone with cerebral palsy was able to function, that actually by combining multidisciplinary physiotherapy, occupational therapy, and speech and language therapy, you could improve the function of what somebody with cerebral palsy could do. Whereas previously people had just sort of thought you can't do anything about the brain injury, so there's nothing to be done. So Bobath Scotland was established in 1995 by a group of parents in conjunction actually with NHS partners to bring the therapy concept to Scotland so that parents could access it. We operate from a centre in Glasgow, but we cover the whole of Scotland. And from what we've realised is that services for people with cerebral palsy are concentrated in paediatric services. They're concentrated around child development and the development of the body. And once you reach sort of the age of 16, but adulthood, there's a feeling that there's nothing more to be done. And so there was nothing for adults. So from 2012, our organisation has been concentrating on how do we support adults and how do we develop a specialist service for adults. And as the organisation grew, it became apparent that we needed to better represent all the activities we do, because we do not just provide therapy, we provide information, we provide support, we bring the community together, we run an annual Cerebral Palsy Scotland conference, we raise awareness of cerebral palsy, we lobby for better policy and services to improve the lives of people with cerebral palsy. And so we had a long-term strategic plan to change the name to Cerebral Palsy Scotland so that people could find us and better understand what we do. Unfortunately for us, I suppose, we had fixed to change our name and to rebrand at the beginning of the financial year in 2020, which was in the middle of the pandemic.
Yes, which we'll come on to indeed.
Yeah.
Thank you. And your current position is Chief Executive Officer of Cerebral Palsy Scotland?
That is correct.
How long have you held that position for?
I joined in January 2012.
And what does that role involve?
So I am responsible for I am responsible for the organisation. I'm responsible to a board of trustees, but I am responsible for the staff, for our beneficiaries, for the services that we provide, for the strategic direction, and basically the buck stops with me.
And I think you say in your statement, in addition to your role as CEO, you also chair the Scottish Government's National Advisory Committee for Neurological Connections.
I do. I was, when that committee was formed, which I think was in 2016, I was appointed deputy chair, and I became the chair in November 2019.
And you're also a former trustee for the Neurological Alliance Scotland as well.
And Cerebral Palsy Scotland is a member of the Neurological Alliance.
And I think you say in your statement that those connections stood you in rather good stead when we, of course, come to the pandemic.
Yes, they did.
You've touched there already on what cerebral palsy is, so thank you for doing that. I was going to ask you that question. How many people in Scotland are living with cerebral palsy, just for background?
The short answer is we have no idea. The longer answer is that cerebral palsy is the most common cause of physical disability in children. Around 1 in 500 births will every year in Scotland will result in a diagnosis of cerebral palsy. But cerebral palsy is an umbrella condition. And because, as I said, it's caused by damage to the infant brain, there tends to be a wait-and-see procedure before a diagnosis may or may not be given. I mean, we sometimes see adults in their 30s, 40s, 50s who have never had a formal diagnosis. So, if something may or may not happen that is detectable, and on average, it's picked up because the development of the child is not progressing as we would expect, and therefore a diagnosis tends to be given most commonly around the age of 2. But as I said, there is this wait and see, because maybe the infant brain is an amazing thing and it may just rewire in some different way. And, there are people who are born have huge issues at birth who don't develop cerebral palsy, and others where, we don't actually know when the damage happened. So that's one of the issues that, diagnosis isn't uniform, it isn't consistent, there isn't a consistent way of achieving that. And, because how people are affected varies so widely, their access and need to services varies so widely. So therefore, we do not know where people live, how many people there are in Scotland, and how they are consuming services. Some lead very fulfilled lives. Cerebral palsy doesn't kill you. Your life expectancy is as normal, but the other things that it might cause and the issues that it might cause you to develop as you age can be extremely significant. And this point about some people need services every day, very huge amount of services for the rest of their lives.
And I think you make that point, don't you, that everyone is different. Just because you met one person with cerebral palsy doesn't mean you met everybody.
Yes.
And I think you also mentioned that there's no drug or procedure that makes that disappear.
No, I mean the thing about cerebral palsy, it's nobody's fault, or tends to be nobody's fault. It's bad luck. It can happen to anybody. It doesn't matter how much money you've got, whether you took folic acid when you were pregnant or not. None of that matters. It is what it is. There's no fancy drug or something, anything, to suddenly be developed, and it's not going to go away.
Thank you. Can I ask you what services your organisation provides to those with cerebral palsy? And I think you've touched on a bit of this already, so I don't necessarily want you to repeat yourself, but there's anything you'd like to emphasise that, you know, how you assist those that do have cerebral palsy?
Well, we provide one-to-one therapy services for families, and that involves their carers and anybody involved in their life. So it could be siblings, it could be teaching assistants, it could be local community therapists. So that is multidisciplinary therapy, depending on what their goals or needs are. That includes physiotherapists, occupational therapists, or speech and language therapists. And actually, we now work with a psychologist as well. We also work and train with professionals who support people with CP. So, we train them to become qualified in the Bobath concept, for example, but we also bring in trainers from around the world for specific issues. We support, whether we run information days for anybody whether it's families or whether it's professionals or students. We've worked with, for example, Glasgow Caledonian University with their physio students. We run our annual conference, which brings organisations that around Scotland and around the UK actually that provide helpful or services relevant for people with cerebral palsy. We also run groups when we have funding for them for specific groups of people. So, for example, every fortnight we have a babies group where families and children who may not have a diagnosis of cerebral palsy but are concerned about motor development. We run a very informal group for families and babies, but we've run groups for teenagers, we've run groups for adults to teach them how to cook or live independently more, and as I say, that's funding dependent. And yes, and we campaign for better services for people with cerebral palsy.
Thank you. Now, your organisation's 25th anniversary was in 2019, and you touched on this at the outset. You had an anniversary ball, I think, just under the wire, as it were,
in February or March. In February, we managed to do our last fundraising event pre-COVID. Yeah.
And you talk in your statement at paragraph 33 about sort of the optimism that you had about the future. The pandemic then, of course, immediately strikes. How did you personally feel at that point, and what were the immediate actions as an organisation you took in light of the pandemic?
Well, I remember that fundraising ball, and we were all slightly nervous about whether we could shake hands or how did we greet people. So we sort of could see that something was coming our way. And one of the things that sort of concerned us was that cerebral palsy was being mentioned as a condition very early on by both UK and Scottish governments. So in the media there was it was given as an example of you might be more vulnerable to this virus if you have a condition like cerebral palsy. So what we saw was that a huge spike in inquiries to us as to what we could do. We also saw a huge raising of the level of anxiety of the people that were coming to see us and were engaging with our services. We'd already started thinking about, there was things like the hand washing advice. Well, if you can't use your hands, and many people with cerebral palsy find it very difficult to use their hands, how do you help someone wash their hands? There was discussion. So we were publishing on our website sort of blogs on how to support people to follow that. And similarly, there were discussions about should we or should we not be wearing masks, and that has an implication for people with CP, not only because they often have communication difficulties, and some have cognitive and difficulty in understanding people. So what was the right thing to do on that? And so we'd had a little feeling that actually we needed to think about these things. we were fortunate that it was the end of our financial year. We just finished some work in Dumfries and Galloway. So, the next, if we locked down, so the centre was locked down and formally closed from the 23rd of March. But in the week before that, people had started to cancel appointments and be wanting to work from home and things like that. And actually, because of the timing, we had an awful lot of report writing and administration to catch up. We didn't have huge amounts of in-person appointments. Staff had annual leave to take before the end of the financial year. So there was a bit of managing that. But when the restrictions hit, the first thing we had to do was, I had to think about, the safety of our beneficiaries and the safety and well-being of our staff. We weren't set up to suddenly go to remote working. We had some laptops, but not enough, obviously, like everybody else. The therapists all had their own iPads, but then there were issues around, how did they access the server? How did they access, secure clinical data, and how is it safe to allow people to work that? And communicate, we were report writing and communicating back to the families what we'd done. So what was the safe way to do that without the IT, gatekeeping of our... we had to manage our way around that. Very quickly, I was thinking, right, we didn't think... I remember talking to some of the trustees. We didn't think this was going to be a few weeks and then we'd be back. We did understand pretty early on that this was going to be a bit of a long-term haul. And so my ambition was to get through whatever it was with my staff intact and the organisation still in existence. And so I remember my chairman saying to me, cash is king. So, we did things like cancel all the organisation's direct debits. We thought if somebody wanted our money, they could come and ask for us. We needed to be in control of what we needed to do. The early weeks were very much in respond mode. We had to, I was thinking about the well-being of the organisation and the staff. The therapists were, and the admin staff were bringing to me these increased inquiries, these issues that were bubbling up. So we were thinking, right, how do we best help our beneficiaries? How do we stay in touch with this population that are clearly worrying about what the effects of the virus are on them? So again, we published through our website, which, remember, was going through a rehaul anyway. We put up, I think we were one of the very first people to put up advice on COVID and cerebral palsy. And we were able to say, the most important thing is to stay fit and well. And actually your best defense against COVID, which we didn't have any clinical knowledge of what COVID was, but we wanted to reassure and encourage our beneficiaries to stay as healthy and as well as possible. We had to quickly, obviously, take the decision about whether we were going to go ahead with the rebrand or not. We decided that we should, because we'd done all the work. It was in place to, go live. The rebranding of the website was different because we needed to keep advice front and centre of any website, and we needed to keep refreshing it all the time. Because what we did was we focused on what we were hearing from the people that were contacting us and trying to respond to that and publish it as widely as we could. So by about early April, we'd sort of identified key tasks that we need to do, and communications was high up there. Funding and how we kept financially solvent, and providing a core administration so that we could, we had a system from our remote working as how did we deal with inquiries and who was the right person to respond and all that kind of stuff. And how did we continue some sort of clinical input to people that needed that. So that was the initial, right, how do we do that while we're all at home?
Thank you. I mean, you mentioned staff there in your answer, and funding. I'd like to ask you about both. Did you rely upon the furlough scheme, for example? Did you maintain your staffing levels?
Completely. I mean, I could never imagine something like the furlough scheme, and I can only describe it as a godsend. It enabled us to, for example, some members of staff had their own caring responsibilities, so, and just wouldn't have been able to be at home and work at the same time. So we were able to give some staff levels of comfort that their job would still be, in place, but they didn't need to worry about us. It enabled us to look forward and budget without just seeing everything fall off a cliff. And we used the furlough scheme for as long as we possibly could, and we were able to identify, okay, what's the skeleton staff we need, what are the tasks we need to do, and we were able to fund it. So, who was and wasn't furloughed was based on need, and it gave us the most immense comfort to know that actually, our biggest cost is our staff salaries, and it was wonderful to know that was sort of taken care of. Thank you very much.
Paragraph 45 of your statement, you talk about the stark contrast of pre-pandemic, where you were welcoming people into your centre. I think you said you were based in Glasgow every day and saw people every day, to suddenly not seeing anybody. Can I ask you how you attempted to, and you touched a little bit on that with the website, but how you attempted to replicate, to the extent that you could, the services that you provided previously to the sort of online space that you were now facing?
Well, we had, during 2019, we had managed as a third sector organisation to sign up and use the NHS. I think it was called Attend Anywhere in those days. It's now called NHS Near Me. And we had been able to sign up to that platform, which was, I mean, thank goodness we had, because that was a safe and secure clinical consulting online platform. And I know other organisations were trying to do sessions via Zoom or whatever it was, but the Near Me platform gave us that ability to run virtual sessions. So that meant that from the beginning of lockdown, we were able to offer virtual clinical sessions. We did, what we found was that what we were used to is being in a room, whether it was in our centre or whether it was in Dumfries and Galloway or anywhere else or in somebody's home. What we were used to is working hands-on and with the team around, whether it's the child or the adult with carers or family or whatever. But suddenly, no, it was virtual only. But it allowed us to deal with specific issues that came up. So, for example, I always think of a family in the Western Isles who had a child through lockdown who was diagnosed with CP, and we were really their only contact with, well, how do I? This wasn't. It wouldn't have been the child that they had expected to have. So what did they need to know as they were looking after their child? We had, very often, again, we were the only people who, people could bring their issues with. So, as time went on, sometimes it was, at the beginning it tended to be very physical issues that people were concerned about. So, I'm getting stiffer, I'm in more pain, I think I'm growing out of my equipment or whatever it might be. But as time went on, other issues became apparent, particularly, I don't feel confident about going outside. I don't want to let people into my house because I'm nervous of infection. So, being able to offer virtual consultations for our beneficiaries, I think, was hugely appreciated and thank goodness we could do it. For our therapists, it was very hard because they are all trained to, as I said, be hands-on, to work collaboratively, and to we had to go from sort of having, if you like, the satisfaction of being able to have time and a number of appointments with people to unpick a number of different things and explore goals or whatever it might be and try things out and all the rest of it, which was how we'd worked before, to suddenly having to identify, well, what's the biggest problem that this person is facing, and what can we do clinically to assist them to help it. So it was sort of going from unpicking lots of clinical issues to saying, no, we need to identify one and concentrate on how do we help that for now. So it was a very difficult way of working. I have to pay tribute to my clinical staff that they, stepped up to the plate and, were absolutely wonderful.
Thank you. You talked earlier about the anxiety that people were facing. I think partly you'd said due to the messaging that was coming out, I think from both the UK and Scottish Government, I think you say at paragraph 48 of your statement. At that time, what was your own reaction to that label, that sort of risk assessment that was given by governments and your own clinicians? Was that an assessment that you agreed with, that those with CP would be more vulnerable to COVID?
I don't think any of us knew. I don't think government knew, and I don't think we knew. And I did... this is where sort of, my predecessor as chair of the National Advisory Committee is, went on to chair or whatever he is of the Association of British Neurologists. And so I was able to speak to people like that and to people in government. I mean, Scottish Government had in post an absolutely wonderful person who was the head of neurological services in the clinical priorities team. And, so people like that, we were able to have a discussion and everybody was feeling their way. I think what we all instinctively understood was that the healthier you could remain and the better you could be, then, the more likely you were to have, to have a better defence against the virus. I think the other thing that was understood, is particularly by us, was that because cerebral palsy is such an umbrella, that some people were clearly going to be far more vulnerable than others. But just by, labelling everybody with CP, that wasn't terribly helpful. And the other thing that we've mentioned is because there is no register, there is no marker on your GP record that you have a diagnosis of CP. Adult social care services don't have a clue who under their great banner of people that are consuming adult disability services actually have CP versus any other condition. So therefore, just highlighting a condition wasn't helpful either to them, it wasn't really helpful to us, and nobody was really thinking about, well, is this right? As time went on, the Scottish Government produced specific guidance for people with neurological conditions, and we were able to work with them on the cerebral palsy part of that. And a lot of that was written by, for example, the Association of British Neurologists. So we were able to sort of pull together the sort of clinical thinking as it was being developed.
And you touched there on the sort of blanket approach, which you didn't necessarily think was entirely helpful. Is that perhaps a lesson learned, would you say, that a more tailored or nuanced approach would have been appropriate, as opposed to perhaps putting everybody with CP into one bracket?
I think the problem is if you don't know where anybody is and you don't know what condition they have, even a tailored approach isn't going to work, because my real issue was that there was no thought given to people with long-term conditions. So therefore, there was no consultation about, well, what would keep you well. Now, I'm not sure how any of that would change, if you don't know where the people with long-term conditions are and you don't know what those long-term conditions are, and there is very limited specialist knowledge in Scotland of ageing with cerebral palsy, apart from actually in our organisation. So until that changes, it just won't be possible to tailor anything.
When you say until that changes, and in your statement in a couple of places you mentioned about the lack of a register, if you like, of those, is that something, again, we're looking at lessons learned as an inquiry, is that something an omission, a gap you think needs to be addressed?
Yes, and what I find really frustrating is that it is actually better for children. So Scotland have something called the CPIPS, which is a children with cerebral palsy. It's actually a hip surveillance survey. So it's not a register, it's not everything, but almost every child with a diagnosis of cerebral palsy is on the CPIPS register in paediatric NHS services. And all NHS areas across Scotland use the CPIPS survey. And what I find really frustrating is the moment these children get referred into adult services, that's just forgotten about. The data just goes nowhere. So my question is always, why not? It's not the total answer, but it's a building block that I believe would be a wonderful thing to keep going.
Can I interject at this moment? You're the second witness this morning, Lady Fraser, who has mentioned the possibility, the desirability of a register. In your case, cerebral palsy, the gentleman that gave evidence earlier on, Down syndrome, where likewise there is no register kept. And I quite understand the persuasive arguments that have just been advancing. It would be certainly advantageous. But obviously that is something which might fall within the remit of this inquiry in relation to recommendations. But registers of persons in a category have, as I'm sure you'll appreciate, potential pitfalls, both legalistic and practical, and in relation to persons as well. Do you have views? I mean, you obviously have a view, it would be a good idea, but have you considered the potential pitfalls and in instituting such a policy?
Yes, and I'm not sure a register as such is necessarily the right answer. But what I would say is that there is nowhere, not even on somebody's clinical record, that they have cerebral palsy. Now, the reason for that is because clinical records are all based on ICD coding, and the coding records what causes, the cause of something. So in the case of cerebral palsy, it might be that somebody has had an infant stroke, for example, in which case the stroke will be recorded, or a brain hemorrhage at birth, in which case that will be recorded. What isn't recorded is the consequence of that. And that's where the CPIPS survey that I was mentioning actually does a better job, because it records the sort of functioning abilities of the child. And I suppose my frustration is, I agree with you. I'm not necessarily sure that registers are the answer, but I cannot understand why in today's age of digital records and the data and information that we gather, that we can't do a better job. And there's some interesting work actually that the Neurological Advisory Committee is currently doing on an epilepsy register, which is looking at, it's cross-referencing pharmacy data with, people that turn up to consultant appointments, with primary care data and others. And I think that's the kind of thing I would like to see advanced for a condition like cerebral palsy. The problem is that we don't have specialist consultants that people go to once a year, as people with epilepsy or MS or Parkinson's or other neurological conditions do. But But what we do have is this CPIPS register, which is an asset that Scottish Government have invested in, and we seem to be doing nothing with it in the adult space. So I think there's huge potential for improvement of identification. And to come back to your point about, that can sometimes be problematic, I completely agree. But people with cerebral palsy feel that they are not counted at the moment. They are invisible. They are at the, they feel at the bottom of the pile for sort of, we don't have specialist consultants. We don't have clinical nurse specialists. They don't get called for annual reviews. There is this feeling that, it's a physical developmental thing. The brain damage isn't going to change. So tough. You're just going to have to deal with it. And that is not right. And that's not correct. And that's why these people, it was so frustrating during this time that cerebral palsy was being mentioned as a condition, which I'm always thrilled it's mentioned as a condition because it's so common. I'm always delighted when people realise that. But the knowledge of what the impact of cerebral palsy is for people is not well enough understood. And that's the thing that I think we could change.
Thank you. That's very helpful. You mentioned in the course of that answer some work being done, reported upon in relation to epilepsy. Is that work published as yet?
Yes, I mean, it's published bits. I mean, there are different stages of it, and it, if you look at the Scottish Government's, I mean, all the work of the National Advisory Committee is published on the Scottish Government's website.
If you had an easy access to that information,
I think there's a link. There is a link to
if you could pass that on to my team, I'd be very
yeah.
grateful and we can follow it up.
Yeah.
Thank you. Appreciate that.
Okay. Obliged, my lord. So just to finish the thought before I move on to ask about something else, is it your view then that perhaps making the tweaks or changes that you've suggested where there is a gap at the moment would have made a tangible difference, or perhaps made those with CP more visible when the response to the pandemic
was
made? Okay, thank you. I want to ask you next about schools. I mean, I don't think you pull any punches on this, so that's why I want to ask you about it. I mean, you certainly expressed the view that you hope that we never again close schools. This is at paragraph 60 of your statement. And then at paragraph 127, I think you go on to say it was a disaster for the CP community. So I think the obvious question we'd ask you is why you hold that view?
I think the point is that schools for this population are more than about just education. So many therapy appointments happen within schools. So, community physios, OTs, SLTs work with children within a school setting. It means that things like equipment is seen and adjusted and, all of that. Schools provide often, the main social interaction for these children. They, that is where that's their only opportunity to be out and meet peers and interact with peers. Let alone the fact that school provides quite significant respite for parents. So I found it quite extraordinary that all these things stopped, that parents were left at home to, some of them might be trying to work from home, some of them might be trying to help siblings as well. At school, some children with CP have one-to-one support to engage in learning and throughout the day, and all that stopped and it was just left to parents. And for all those reasons, it left families unbelievably isolated, dealing with problems that were just ignored, things like growing out of equipment, or it disengaged these children from the curriculum. because if you have a support worker to help you engage in learning, and suddenly you're at home with your parents and your siblings and all the rest of it, that's pretty tough, putting it mildly, and it exacerbated the isolation that these families felt.
What would you suggest then might have been a different course to take, a middle ground or alternative to what was actually done then in relation to schools?
Well, I mean, I'm sad that home visits, in-person visits, didn't happen. I think people that required one-to-one support at school, it was extraordinary that they didn't have home visits at home. Families reported to us about, people would phone them up, "Are you all right?" And in our very British way, we'd say, "Yes, we're fine," kind of thing. But actually, there was no real interaction there that we could see. I think the other thing layering on top of that is always the anxiety. Families were already unbelievably anxious about their vulnerable child, and so therefore there was an anxiety about, well, even if there was a place, because I think technically these children could have attended schools, but put on top of that your child is more liable to be vulnerable because of their cerebral palsy. So families, were absolutely, so many I can think of that just stayed at home far, far longer than any of the rest of us, even after schools opened and restrictions lifted. There was a real nervousness about going back into that environment. And I think that was caused partly because, as I say, cerebral palsy was being pointed to, but also, there was no dialogue really with families about what would have made it better for them, what could have kept them engaged, or what did they need. It's back to nobody asked these families what did they need to continue educating their children, in terms of development and all of that. There was just no thought given. So that's why I feel quite strongly about it.
Glad I asked. You said no one asked. You yourself as an organisation carried out a number of surveys, as I understand, and we see that referenced at paragraph 65 of your statement. What did the results of those surveys reveal to you in general terms, and also I think about mental health? Because we've talked a little bit about physical health, you've talked about things like physiotherapy, speech and language perhaps not being offered when schools were closed. What were you seeing in terms of the results of those surveys on the mental health side?
We did 3 surveys during this period. So May and September 2020, and then again in February 2021. And what we found in the May survey was that the biggest issues tended to be physical. So they were stiffness, they were pain, they were things like growing out of equipment or splints or whatever. What we found as time went on, that the reported issues of decline in mental health sort of rose significantly, and what was important was that this decline in well-being wasn't restricted to the person with CP. It was felt. I mean, I think I've got a figure here of 44% felt it had also impacted on other people in their family, and people reported that if they had someone with CP, child or adult, at home, then the whole family stayed at home and felt and were restricted in what they did. We looked at care arrangements. Care arrangements obviously were totally scaled back at the beginning, but by February 2021, 63% were reporting that the care arrangements they'd had pre-COVID still had not been reinstated. Very common was this feeling of isolation, whether it was a choice or whether it was that's how they felt. I don't know, but the feelings of being isolated because of their condition increased. And what also concerned us was access to healthcare. So, 17% reported they hadn't even been able to speak to their GP or other healthcare professional. Appointments were cancelled, and not rearranged, sometimes at very short notice. So this lack of access to what I would consider essential health services wasn't there, and that was very concerning to us.
And so therefore, is your evidence then, would you suggest that a reconsideration or a different approach should have been taken to what was deemed essential?
Completely. I mean, I think, it astounds me that we all decided it was clearly essential that we all had an access to a supermarket and could go and buy our food and milk and toilet paper and all the rest of it. But for our population, access to physiotherapy, occupational therapy, and actually, being able to access that through venues like schools rather than just in healthcare settings, that is essential.
Yeah. Thank you. And I mean, to complete that, then, were you ever asked for input into what should be deemed essential? Did your organisation ever provide any input to the Scottish Government about what that should be or not?
When asked, we provided an opinion whenever we could, but the feeling we got is that the different teams we were talking to at Scottish Government, so my main interaction was through the clinical priorities team, who were as helpful as they possibly could be, but we also had interaction with, for example, the shielding team, who seemed to have been, I suppose unsurprisingly, but assembled at the very last minute to look at this, had no prior knowledge of this area, and it was any input we had, it seemed to be well received, but it didn't necessarily go anywhere. So this lack of coordination about who did what and who was listening to whom was difficult to understand whether anything we said was landing with any impact.
So your thoughts were given, but not necessarily actioned, I think is what you're saying. Yeah.
Yes.
All right. You mentioned that word shielding. I was going to come on to that anyway, so let's do that. When shielding was first announced, was it clear, in your view at least, how that applied to those with CP?
No. I think the thing with shielding is that there was perhaps a lack of understanding both for the people who were being asked to shield and from the people who were asking them to shield what it actually entailed. And, as I say, we did have meetings with the Scottish Government shielding team, and we did raise the issues around cerebral palsy being an umbrella condition, that some people, it would be very, very badly affected and therefore possibly need to shield and others wouldn't. But the lack of being able to identify who any of these people were and where they were was going to be an issue. What we found when shielding was announced was that, again, people who felt they were vulnerable, because remember, we've been telling them since March that this population was vulnerable, again, the anxiety rose. So the inquiries we got were from people who, I think the other thing, if I remember correctly, that the letters went out to ask people to shield, not all at the same time. So, and not, so therefore some people got letters and some people didn't. But for people with CP, they were being asked by very different professionals to shield, or not, as the case may be. So the inquiries we got were, should I be shielding? Or who should I talk to about shielding? Now, we, as an organisation, were absolutely not in a place, nor did we want to be, to make that decision. So we would refer people to their healthcare professionals. But then there was an issue about getting hold of their healthcare professionals. So not everybody with CP has a consultant neurologist. Not everybody with CP has a community AHP that they can talk to. Many spoke to their GPs, but GPs do not have a specialist knowledge of CP. I mean, I don't want to denigrate any GP in this, but so what we found was that many professionals were if they were contacted by someone, would err on the side of caution, and therefore, people were being advised to shield. I just want to read something from one of our surveys that a parent wrote in. We were fortunate that my child's consultant still scheduled my child's routine appointment, which allowed us a very sensible and pragmatic discussion on practically interpreting shielding policy. I feel that all parents would have benefited from such a discussion. And I think now that was a child who was clearly talking to a consultant paediatrician. And children do have access to paediatricians. Adults do not. There isn't an equivalent. So, so therefore, who they should be talking to, it tended to be really ad hoc. So we had people that were sent letters that were asked to shield, people that contacted us and or their healthcare professionals to ask if they should be, and if they did that, our experience is that people tended to err on the side of caution. And then there was another group of people who felt so anxious about the whole thing, they chose to shield themselves. And yeah, whether that was right or wrong, I think there were lots of unintended consequences of shielding.
No, thank you. And you used those words ad hoc. Do you think, therefore, perhaps, is there room for improvement? Would there have been room for improvement there?
Well, I come back to my data,
yeah.
I'm afraid. My point on data is that if we understood where these people were, where they lived, and what their level of function was, then we could have had a far more systemic approach to what could have been done. And how they were communicated with, because if they were very mildly affected by CP, we could have communicated. Healthcare professionals, local councils could have communicated with them to reassure them. So on both ends of the spectrum, data would have been brilliant.
And of those with CP who were asked to shield, or as you say, some people who perhaps chose to do so because they felt they needed to for anxiety reasons. Was there any particular consequences of having to do that you would highlight, adverse or not?
Well, mental health issues were significant. Feelings of isolation, feelings of anxiety, access to any support and help and interaction about their condition was sort of non-existent. I mean, again, if I go back to our surveys, people were saying, if I hadn't been able to talk to Cerebral Palsy Scotland, I don't know what, I don't know who else I could have spoken to about my condition. And so I think the mental health impact of shielding was enormous. And again, I come back to the fact that if one person in the household had cerebral palsy and was either shielding or chose to shield, then we know of many instances where the whole family felt like that. We know of families who then, shielding was over the summer. Schools opened to, in August to an extent, but those that were shielding were not about to send their children back into the school environment, nor were they advised to, and as a result of that, we know of families who took a very long time to even leave their houses. I mean, we had one particular family we worked with, a good, I'm talking summer 2021, not 2020, and it was about let's go leave the house and go for a walk in the local park. that was the level of anxiety that we were dealing with. So I think the other thing is that in the adult population, we saw adults who had chosen to move back in with elderly parents. And so there was that combined effect of, the older you were, the more susceptible you were being told you were, ditto with cerebral palsy. So the isolation of those families and the stress that elderly parents felt caring for their adult child with CP, it just compounded because it went on and on and on and on.
And you mentioned the mental health impact or consequences there. On the physical side, was there any consequences you noticed also, people having to shield?
I think it's back to this access to what I've already said we would consider essential services. So, physical side, it's things like increased pain, increased stiffness, decline in function. The great thing with muscles and your body, if you don't use it, you lose it. And that is the same for people with CP. So, if they're not able to, be out and about, have access to physio or whatever it is that keeps them well. I mean, some people, accessed, hydrotherapy, local swimming pools, whatever it is, and all those were shut too. So not being able to keep active had a physical issue that once lost, it's very, very difficult to bring back that kind of function. And it is not surprising to me that if you are seeing yourself being able to do less and you are in greater pain and you are stiffer and you're not seeing people and not socially interacting, no wonder your mental health is going to decline.
Yeah. Were you able to help families, individuals with CP that were suffering these things at that time? Is that something you could assist with? So
we work with clinical psychologists, and we were able to offer virtual, and we still do. We offer. Then it was all through Near Me, and we were able to offer appointments. Regarding the CP, I mean, where we're clear is that, we are not a general mental health service. We are about if your mental health is in decline because of something to do with your cerebral palsy, then we can assist and help with that, and we have a clinical psychologist who was able to do that.
Let me ask you this final question then on shielding. In your view, was the balance struck correctly then on the shielding guidance that was given the consequences that you've outlined, mental health, physical? Was the approach taken to shielding, in your view, the correct one?
Well, if I speak completely personally, I am not convinced that we ever needed to shield. So I'm not convinced the shielding policy was the right one. But that is a personal view. And I think we are still dealing with the tail end of the issues that have arisen from that.
All right, thank you.
Stephen, you've got about 15 or so minutes there left.
My Lord, very timely intervention, because I don't have any further questions for the witness.
Must be a mind reader.
So, very grateful for your evidence today, both in writing and orally.
Mm-hmm.
This is your opportunity, I suppose, if there's anything you would like to add that we haven't covered or you'd just like to emphasise before we conclude.
Well, first of all, I'm always grateful for the opportunity to speak about people with cerebral palsy, because it is such a significant population, and it is, I call it the Cinderella condition, because it is just forgotten about. And my reflection on all of this is that it seemed that people, throughout anything to do with COVID at all, people with long-term pre-existing health conditions were very, very low down the priority list for healthcare services and others. And for many, with even these basic support services not continuing, that was what caused the biggest issues, not the COVID. And what depresses me is that they are still low down on the priority today. So nothing has changed. So my hope is that it just might.
Thank you very much.
Thank you.
Thank you.
Very grateful, Lady Fraser, for your most helpful contribution. Thank you.
My pleasure.
Right, we shall come back. I think we're scheduled to come back at 12. With beg pardon, 1:30, and I think that's probably possible. Is that? Do you know that, Mr. Stephen?
I believe so, my lord. Yes. Yeah.
Jolly good. Excellent. Thank you. 1:30 then. Thank you.